I would like to welcome everybody to tonight's session and good evening and welcome to tonight's webinar on genetics in primary care. We thank you for taking some time out of your evening to join us. My name is Angela Heathcote and I'm from Eastern Melbourne Primary Health Network. We welcome our guest speakers for this evening, Dr. Kunal Verma, a clinical geneticist and cardiologist, and Dr. Shamala Panwar, a GP consulting in Brunswick and Northcote, and also works supporting our PHN team in a clinical editor reviewing the genetics suite of HealthPathways Melbourne. I would like to start this evening by acknowledging the traditional custodians on whose unceded lands that we are gathering on this evening, and from all areas that you may be dialing in from. Tonight, I am dialing in from the lands of the Wurundjeri people, a very short walk to Mullumbullen Creek, where on a beautiful sunny day like today, I'm reminded of the beauty of this area at my doorstep, from the peaceful walk along the bushland that runs the entire length of the waterway to listening to the local bird life, such as the black cockatoo. We also acknowledge the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples today. So before we begin tonight, just to let you know that all attendees are on mute. Dr. Verma has a very interactive and engaging session tonight, and we'll call out for contributions throughout the webinar. Please add your comments or any questions to the chat box and Q&A, and Dr. Panwar will be facilitating these with Dr. Verma. I would like to welcome and introduce our first speaker, Dr. Kunal Verma. Dr. Verma is Australia's only dual-trained clinical geneticist and cardiologist. He is a Monash Health physician and will be providing cardiovascular genetics care to patients at the Victorian Heart Hospital when it opens in 2023. He is also Director of Progenics, a private genetics practice at Cabrini, Melbourne. So good evening, Dr. Verma, over to you.
Thanks very much, Angela. And to everyone who's attending, this is about your learning. So, please feel free to ask any question you like. You can even message Shamila directly if you're too shy to ask a question, and, she can pass it on to everyone in confidence. The point of the session is to make sure that you all feel like you're a bit more empowered in the genetic space. Because from speaking to GPs, I understand that this space is rapidly evolving for non-genetic specialist physicians, let alone GPs, and you've already got so much on your plate as general practitioners. So I'm not surprised when GPs tell me I really don't know, where to send, how to send, who to send for a lot of cases. So I'm trying to build a picture that's of the genetic medicine that's relevant for your practice every day. But, please feel free to ask any and all questions. I work at Monash Health. I also am about to join Alfred Health as a geneticist, and then Progenics is my private practice, and I consult out of Cabrini in Melbourne. So I'm going to just talk about some basic concepts first. This will take you back to medical school, but it's important. Some really key tenets that will help you understand a lot of what we do in genetics. We know that our genes are packaged into chromosomes. What you might not know is you inherit about 20,000 genes from each parent. So you inherit 20,000 pairs of genes. And the best analogy that I've come up to date with is that think of them as like books in a library, hence the library images in the top right. You've got books stacked on massive library bookshelves, and you've got 23 bookshelves, analogous to 23 chromosomes in your library. And you inherit two libraries, one from mum, one from dad. And these books are all different kinds of sizes, all different kinds of shapes, signifying that they code their genes and they code for proteins that are involved in every single aspect of your development and function. That's your 20,000 books condensed onto 23 chromosomes. And then what you can do is you can read individual books. The image on the top right showing you can pick select books out of your bookshelves and interrogate them for mutations or spelling mistakes. And another key concept is that we are riddled with mutations. So we're essentially all mutants. We have far more mutations that are common between us than those that are rare between us. But we also have our own rare private mutations. In fact, each of us in the webinar has our own 50 private mutations that no one else in the world is thought to have. Okay, so they're completely unique to you. And that's problematic because when the laboratory finds one of those mutations, the laboratory reports back to me or to you and says, I found a mutation, but it's never been seen before. Does that mean it's the cause of the patient's condition or not? I simply don't know. And that's one of the reasons why we get uncertain results, because there are so many mutations in amongst our genes, so many what we call variants is the better term now, because mutant carries so many negative connotations. So we use the word variant and interchangeable mutations. So yeah, our genes are riddled with variants, many common, many rare. And in genetics, we focus on the rare ones, and I'll come to that in a minute. The next and most next important concept I wanted to impress upon everyone is the analogy I've given you is 20,000 books stacked neatly into bookshelves. But the reality is actually, if you laid out all the words of these books in a long line, you'd spell 3 billion letters. But in actual fact, most of these books are full of what we call junk DNA. They're full of DNA that doesn't code for the protein that's eventually seen in the body. So the protein is, I'm making up numbers, 1,000 amino acids long, but the book actually has enough letters to code for a protein that's roughly 100,000 amino acids long. So it has, 99 times the amount of genetic material or letters that's required to code for the protein. And that 99 times or 99% of letters, a total length of letters, if you laid out every single letter in those books, is 3 billion letters. Okay, that's your gene, that's your genome, genetic code. Of that, only 1%, roughly 1 to 2%, is actually coding material, stuff that codes for a protein. And that's where we focus on our interrogation on our genetic testing on, is on the 1 to 2%. And the bottom, what I've shown you is there's actually a browser. There's several browsers, actually. You can actually browse the genome. You can scroll through letter by letter, chapter by chapter, someone's 3 billion letters. And the bottom, it shows a particular gene. And the little bars represent the sections of the gene or the mini chapters of a very thick book that code for the protein. But the remaining stuff in between the mini chapters is what we used to think was junk DNA. It doesn't code for the protein. We used to think this is all just useless, a vestige of evolution, but actually we realize it's all very important. It regulates the mini chapters that are really important. But the point I want to make here is we don't know what 98% of the genome does at the moment. We know what 1 to 2% does, and we focus on that in our testing. But when it comes to the other 98%, we know it's there, it's important in some respect, and it just goes to show the eventual explosion in knowledge, because we're only focusing on 1 to 2%. I'll show you how much we can do with just that 1 to 2%. Forget about the 98%. This is the test that we used to be able to do as the only genetic test we could do. It's called the G-banded karyotype. It's where you look down the microscope, you force leukocytes into reproduction. You give them, you chemically force them into mitosis. When they start dividing, you then arrest them in mitosis, and then you stain them up with Giemsa, which is why it's called G-banded, because Giemsa is the stain. And you look down and you arrange the chromosomes, and you look down the microscope, and on the right, you can actually see them. And this is what a cytogeneticist does. They look down and look for major chromosomal abnormalities, essentially large portions of bookshelves missing or duplicated or in the wrong region. That's what a G-banded karyotype is. And that's all we could do 30, 40 years ago, looking down the microscope. But that tells you nothing about the individual books in those bookshelves, just about hundreds of books together, missing, moved, duplicated. However, there's been a rapid rise in genetic testing technology. Now we can sequence letter by letter genes, and we can do it very quickly and cheaply. The first genome, meaning the first attempt worldwide, was a massive effort. $4 billion. Took them 13 years, 1990 to 2003, to sequence each and every letter of your 3 billion letters. It took them 13 years. Now you can do each and every letter overnight for 1,000 Australian dollars. So you can just show you, it's exponential doesn't begin to describe the change in cost and accessibility of genetic testing. And it's all because of this thing called next generation sequencing. You'll hear this term time and time again in genetics. It's also called second generation sequencing, also called massively parallel sequencing. They all reference new technology that allows you to read thousands upon thousands of segments of genetic code in parallel. So if you lay those 3 billion letters out in a line, you can read 1,000 segments of 150 letters in a couple of hours, thousands of segments of each of 150 letters in a couple of hours, and then read another few thousand segments of 150 letters in a couple of hours. So you can see how in a few hours you can cover the whole 3 billion letters very quickly. So to give you a clinical perspective now, this is the end of sort of the background. To put it into perspective clinically, this is a genetic test report for a young lady who was thought to have Marfan syndrome. This is what it reads. In the middle, you can see the test requested. It says mutation screen of the FBN1 gene, which is a gene responsible for Marfan. And back in 2005, this is 18 years ago, we had to do it gene by gene. You'd have an even segment of gene, mini chapter of a book by mini chapter. Sequence one mini chapter, read the result, then sequence the next mini chapter, read the result. It could take you months to sequence a whole book. And that's just the coding, the 2% that's important, we think is important, not the 98% that's not important. That's gene by gene. Now, a genetic test report. This is a more contemporary test report. This is from 2019. And on the right, forgive me, you can't see my cursor here, but on the right, on the method section, it talks about a gene list, and it talks about a particular gene list called the mendeliome. And this is the mendeliome. This is the roughly 4,000 genes, 4,000 books that we know are associated with some disease or the other, eye, brain, heart, kidney, whatever it might be, intellectual disability, epilepsy, whatever you want to, and I'll talk about all the different conditions you can test for. You can sequence all of these genes concurrently in the same test, if necessary, in 12 hours. So it's indescribable, the change from segment of gene by segment of gene to 4,000 genes in the one test. And that's the power of the current testing. But with that power comes a lot of confusing stuff that I'll talk about. And that's what confuses people at the moment, because when you go and order this kind of testing, sometimes you find stuff you don't want to find. Sometimes you find things that are incidental. Sometimes you find things that are uncertain. And so I'll talk about those complexities, and that's where genetic counselling comes in, why genetic counselling is so important. Shamila, are there any questions at this point that people want to answer? You're happy for me to keep going?
I can't see any questions. But it's the first time I'm doing this. If there's questions that you've asked that I can't see, please just shout out or somehow message us. But it looks blank to me.
Okay, great. Well, sometimes that's good, sometimes bad. I'll keep going, and we'll see how we go. So the other thing I wanted to highlight for you guys is, in brief, reading letters, reading genetic code is a type of test. It's a sequencing test. And you can do that via the old technology, Sanger sequencing. You can do it by new technology, which is picking dozens, hundreds, even thousands of genes and sequencing all up at the same time. You can pick what you want to sequence. You want to sequence 5 genes, 20 genes, 100 genes, which ones you want to sequence. And if you do it parallel or these days, we almost always do it in parallel because it's so much cheaper and more effective. But there are other types of pathology. One is methylation, which is the sequence is just the same, but there's chemical alterations. Second is the sequence is just the same, but it's been flipped over. So it's reversed. It's what's called a structural rearrangement. That's why G-banded karyotypes, you look down the microscope and you see the chromosome, and the sequence is just fine. One segment has been reversed or inverted, we call it. That's a rearrangement. Then there are problems where the sequence is fine, but there's a segment that's repeated. It's called a triplet repeat disorder, where, the letters, like, for example, Huntington's disease is a triplet repeat disorder. That book, the HTT book, the Huntington book, everyone's got that book. And in the people with Huntington's, they've got, imagine a particular page out of that book should only be 17 lines long, but that page is 22 lines long because the word CAG, C-A-G, that's the repeat in Huntington's. It should only be repeated 17 times on that page, but it's repeated 100 times on that page. And so the whole page is the wording, the words are longer on that page, and that's the problem. It's not that the whole sequence is abnormality, or it's not that there's a spelling mistake, it's that there is a repeat that's there too many times. So there's different kinds of pathologies. As a geneticist, we know which certain pathologies require certain tests. 90% of pathology that we focus on is on sequencing tests, which is why we're going to focus on that today. But there are some pathologies that will not be picked up by sequencing tests. And that's where we come in to say to me, do a methylation test. For example, something like Prader-Willi syndrome, which is a childhood syndromic condition, which is not going to be picked up on a sequencing test, that needs a methylation test. Or Huntington's, which needs a triplet repeat test, just to give you a perspective that there are different kinds of tests that we do, but the vast majority would sit within the sequencing test. So now on to...
on that note, sorry, there's a question that's just come up, which is asking, is it necessary if you carry a bad gene, are you going to get the disease?
Yeah,
so what happens?
Yep. So it all depends on the condition. So in the cardiology sphere, for example, if you carry, well, we all have the Marfan gene, FBN1. I've got it. Shamila's got it. We all have FBN1. We've got 2 copies of that in both libraries, one in both libraries. If you have a mutation or variant in 1 copy of FBN1 gene that causes Marfan, you have an increased risk of having the Marfan problems, aortic root dilatation, et cetera, but not 100% chance. It's what we call reduced penetrance. Whereas in other conditions, there is 100% penetrance. So for example, in Huntington's, if you've got more than 50 repeats of the CAG repeat on page 17 of the Huntington book, which you can tell through a triplet repeat genetic test, you are going to get Huntington's. And we can predict with relative accuracy within 5 years when you're going to get Huntington's too. So it depends on the genetic condition, whether if you have the problem, the variant, the triplet repeat, the methylation issue, whatever it might be, whether you're definitely going to get the condition or not. Okay, so I wanted to highlight here why we do genetic testing. It's no longer scientific, like good to know, but not much can be done. A lot can be done now. I'll talk about what can be done for the person and then what can be done for the family. The person, genetic tests can make a huge difference in terms of making a diagnosis. Okay, you think they have Marfan, you don't know, the questions that hang over their head their whole life. Do a genetic test, find an FBN1 gene mutation and say, no, it's unequivocal now. You have Marfan. Patients have undifferentiated neurological presentations, seizures, regression in children. You do a genetic test, you find a specific mutation, you make the diagnosis very clearly. So it can be very powerful, people. And we know there's some literature out there that shows that patients who come through genetic clinics typically go through an 8-year diagnostic odyssey, usually kids we're talking about here, before the massively parallel sequencing test finds that one genetic mutation that makes the diagnosis in that child. But now we can go straight to it, and I'll talk about that. There's Medicare funding that allows everyone to bypass that arduous long process and go straight to the whole exome sequencing test and look at all those 4,000 genes at the same time and get an answer quickly. The next thing is the diagnosis can often risk stratify or prognosticate. So if they have familial hypercholesterolemia, for example, through a genetic test, you can say, okay, you don't just have high cholesterol. You have high cholesterol and independent of the fact that your cholesterol is high, you've got an elevated risk of heart disease. We need to get on top of that really quickly. And there's now PCSK9 inhibitor therapy, for example, for FH. Another example of risk stratification is someone's got early onset cognitive impairment. And at the moment, it's just mild cognitive impairment. But you make the diagnosis of frontotemporal dementia on a genetic test. That's very clear in terms of knowing what the trajectory of that person is. It's not going to be just lingering on for 10, 15 years. This person is going to get worse, and it's going to get worse in the next 5 to 10 years. And based on other people who carry the same variant, you can provide the patient, the family, some sort of guidance to say, I suspect it's going to go this way this soon. So it makes a big difference in that respect. In cardiology, it makes a huge difference in terms of treatment implications, and I'll talk a bit about that. We have defibrillators, pacemakers, medical therapy, surgeries for hypertrophic cardiomyopathy, all based on the genetic diagnosis. Undifferentiated, not sure why this person's got so many ectopic beats. Why have they got a reduced ejection fraction? They haven't got blocked coronary arteries. Their valves are okay. They haven't had chemotherapy. We don't know why. Do a genetic test, find a genetic dilated cardiomyopathy, and you've found your answer. So, okay, I know why. And this is the one that's particularly associated with sudden death. So think about implanting a defibrillator early. So it has implications for diagnosing, risk stratifying the person, prognosticating, as well as treatment implications, real implications in many fields, not just in cardiology and in neurology. And then you can identify other people in the family, siblings, children, parents. And a real utility now is there's Medicare funding for using IVF, what's called pre-implantation genetic diagnosis on the left there, to select embryos that do not carry the mutation that causes disease in the family. It can be done all Medicare funded, bulk billed, all of the IVF, because there's funding now for that. So people can also test their pregnancies to conceive naturally, test the pregnancy, do an amniocentesis, sample the fluid, test the fetal DNA, and make a decision to terminate because the baby carries a rare severe disorder that the family don't want the baby to suffer from. So you can do a lot now. It's not just good to know, it's important to know. It changes how you look after the patient and their family. The scope is huge. In essence, you can think about any corner of genetics, a corner of clinical medicine that has in its own field some pathologies that are monogenic, meaning single genetic change. And I'll go back to this slide. This is really important. What we deal with in genetics actually is single mutation or single variant in a single gene causing a problem, right? Single variant causing cardiomyopathy, single variant causing retinitis pigmentosa, single variant causing monogenic diabetes. And you can then track it through the whole family and pick up who else could be having it. So this is what we focus on in genetics. What I do in my public and private work is focusing on monogenic disease. There's also polygenic risk scores and stuff. That's not yet in clinical practice. It'll come, but this talk and what's currently being used is not focused on polygenic. It's on single change in a single gene causing a single problem. And there's single gene disorders in every facet. We start from the bottom left, preconception and pregnancy. You know that you do carrier screening, and I'll talk a bit about the complexities, not the basics, but what you should be aware of when you're ordering carrier screening. And in pregnancy, we do non-invasive prenatal testing, NIPT, NIPS, which we do now. In pediatrics, so many single gene disorders, thousands now that have been described, intellectual disability, syndromic for children. And I'll go through all of these. I'll give you some examples. Cardiac, eyes, kidneys. In every facet of clinical medicine, there is a little pocket, and increasingly the pocket's getting bigger because it's blurring with common diseases where there is a single variant, a single gene causing a single problem. And so if you have patients that have unusual pathology, that are young, that have unusually severe or unusually severe common pathology, or just unusual pathology or rare pathology, or they have a family history, and in particular, if they're family planning, think about genetics. Think about referring them on for a genetic evaluation.
On that note, sorry.
Yeah.
Another question, sorry, on that topic. So the question from Jane is, do GPs just request testing for familial hypercholesterolemia based on very high cholesterol, or do cardiologists order it?
So
when you want us to do it?
Yeah. So actually, Jane and everyone, GPs can actually order a lot of testing. Okay. And I'll show you what you can order. There is a difference between what you can order and what is funded. That's the issue. There are certain, and I'll talk about that in a minute. There are. In fact, let's talk about it now, and I'll come back to hypermobility. There's the next slide. There are certain tests that you can order that are also funded, meaning they're Medicare funded, meaning the patient's not out of pocket. And I've given you some examples. For children with autism, developmental delay, you can already order a chromosomal microarray, that's a CMA, and a Fragile X. You can just write, developmental delay, intellectual disability on your path form. The laboratory knows the item number, they will do it. You can already order hemochromatosis genetic testing. You can already order thrombophilia genetic testing. Celiac disease, I'm sure all of you order all the time. That's a genetic test. It's Medicare funded, looking at whether you've got a particular sequence variant or not. That's what DQ8 and DQ2 are essentially. They're just spelling errors. You've either got this error or that error. And the lab tells you which error do you have or not. And then cystic fibrosis testing, if you've got a family history or you've got a partner who's positive, you can order that test now, Medicare funded. You can also order testing for familial hypercholesterolemia, cardiomyopathy, dementia, neuropathy, myopathy. Labs nationwide, international will accept your request, but they'll ask you for two things. They'll ask you for a consent form, which I'll talk about, because those tests are much broader. They're wide-reaching. They could find something the patient may not know about. There could be massive insurance implications, blah, blah, blah. They'll ask for a consent form, and they'll ask for payment. Then there are tests that specialists can order, because that's what the MBS item number specifies, that it has to be ordered by specialists. And FH testing falls in that category. So, Jane, you can order it, but the out-of-pocket cost currently is about 500 Australian dollars for a patient. If you ordered it, they came through a specialist and they met the criteria, it would be funded through Medicare. And so so there's Medicare funded for GPs, there's Medicare funded for specialists, which I haven't covered here, but they are specifically in the pediatric sphere. For intellectual disability and ID, you can order whole exome sequencing now, which is the next step up from a microarray and a Fragile X, looking at thousands of genes to find an answer. In cardiac, there's lots of Medicare funding, cholesterol, cardiomyopathy, arrhythmias. In kidneys now, there's Medicare funded. You can order whole exome sequencing people with unexplained kidney disease, because we know we can find an answer. It can help the next generation picking pathology and preventing passing it on. And in some situations, it's associated with cardiac problems. So you now know, okay, I need to screen this person for cardiac disease because I've found an answer to their kidney disease and they're at risk of aortopathy, for example. So that's the Medicare funded, but many tests still aren't Medicare funded. In fact, the majority of testing clinically that we'd order is not Medicare funded. So then what are the two options? You can either come through a public genetics clinic, like at Monash where I work. Out west, it will be at the Royal Women's for pregnant women, for women rather, Royal Children's VCGS for children, Royal Melbourne for adults. Out east, it's in Monash, Austin, Genetics in the Northeast, and Shamila will show you these genetic services and the health pathways that are embedded in the health pathway that she's written. You can refer there, and if they're seen there, they access state government testing. That's the bottom dot point. So the state government funds tests that aren't funded by Medicare. When a group of geneticists together think it's worthwhile doing it, we think there's a reasonable chance of finding a diagnosis. We think it might impact patient care. There's someone in the family who's family planning. This is the kind of thing we take into account. And roughly, and specifically, 3 geneticists have to agree that, yep, we're happy to, put state government funding about $1,000 to $2,000 towards this patient's genetic tests. That's one avenue. The other avenue is privately funded. It used to be $3,000-$5,000 for a privately funded test, but now it starts at $500 if you come and see someone privately for me, like me, for example, for dementias. Cardiac testing isn't funded. Eye testing, pediatric testing isn't funded. All those realms that I talked about, in all these realms, there is panel testing, multi-gene testing, dozens, if not hundreds of genes in parallel as a panel, can be funded by the patient for approximately 500 Australian dollars now, which is massive in terms of accessibility. Granted, not everyone can afford that, of course, but a large proportion of the population can afford that, much more than they could afford $5,000 per test. The other thing that in funding is that, there are other tests that you can order already now that can be patient funded. You already know that you can order NIPT testing, carrier screening testing. That's all patient funded, not yet Medicare funded. Pharmacogenomic testing, GPs can order right now. It's not Medicare funded. The patient's happy to pay. You can order that test. And then I'll just highlight for you paternity testing and lifestyle wellbeing testing. And the reason why I put those logos on the top right, I would really caution you about genetic test reports patients bring to you. Always look for those 2 logos in the top right. RCPA accredited and NATA. NATA is the National Association of Testing Authorities. Basically, a lab has to go through stringent quality control and demonstrating proper testing to achieve both that accreditation. And you'll see on some of the genetic test reports that I show up that both those logos are on those test reports, signifying that the lab has met the same criteria that, for example, Melbourne Pathology has to meet to do a full blood count, or Dorevich has to meet to do a histopathology for a breast biopsy. It's that level of accreditation, not the 23andMe level of accreditation, for example, where there is no accreditation. You can buy that off the shelf. So that's what I talk about with lifestyle wellbeing testing. That's through unaccredited labs that patients order. I had a patient come through my private practice who saw someone in Queensland who she paid $1,800 to for Ehlers-Danlos testing, only to learn that it wasn't accredited. It was just a possible risk of Ehlers-Danlos. It was honestly crap testing. And I feel very bad for her because I've offered her now an accredited $500 test and she seems to be grateful. But had she known that, she would have saved herself almost $2,000 had she come to a geneticist to talk about that rather than gone fishing online. Any other questions, Shamila?
There is a question. It's a specific one. I'm wondering, I might leave it to the end of the chat until
Sure.
the end of the presentation, then we'll come back to it.
Sure. So that's the funding. Now I want to talk about hypermobile Ehlers-Danlos syndrome, because this is something that you will come across, and I know GPs come across all the time, the bendy stretchy and query Marfan. In essence, this is what I tell patients, and I would hope that you can understand this at this level too. Hypermobility is just on a spectrum. Some people are just more flexible than others, signified by that bell-shaped graph. And at that end of the spectrum, the more flexible you get, the more likely you are to develop as a female, particularly, childbearing age female, those additional problems on the right-hand side, the chronic pain, migraine, POTS, IBS, all that stuff. That doesn't mean you're going to get it. In fact, the majority of hypermobile people won't get those things. But we do know that there are people in whom hypermobility plus this stuff clusters together. We don't actually know why, but we know it runs in families. We know it's very common to in that age group, and that it's not a made up thing. It's a real thing. These people are actually experiencing these real symptoms because they're reproducible. You can see them in other people as well, independent of psychiatric, psychological pathology. In that group of people who have hypermobility and other issues, a very small proportion have rare disorders that are masquerading as hypermobility with stand loss. And they're things like Marfan and these rare conditions called vascular EDS and Loeys Dietz. Very small proportion. Of the 100 women I see with hypermobile EDS, I tell them all the same thing. And because I almost never find any physical signs in them pointing towards Marfan or vascular, I tell them the point of you coming to see me is to see if I can find me signs. I did not find me signs. And I expect that because these conditions are rare and hypermobility is common. So I expect not to find signs. Didn't find any. You can do a genetic test for these rarer conditions. The test is approximately 500 Australian dollars. You don't have to. I do not think it's likely. I think it's a 1% or less chance you have it. Some people fund it, some people don't. That's their choice. But that, in a nutshell, is hypermobility and hypermobile EDS. They're on the one end of the spectrum. They can have significant disability. The diagnosis doesn't always suit everyone. I talk to people all the time about, do you think it's good for you to have this label or not? Some people struggle with the label. It's just another thing they have to carry around on their shoulders, like chronic fatigue and myalgia and fibromyalgia. Whereas others think it's liberation. It's an explanation for everything they've had to face, and it allows them to target which physiotherapist they go to, which integrative physiotherapist, which particular cognitive specialist they should go to. So I talk to them about that. That's my approach to whether, because as you all know, putting a diagnosis like chronic fatigue or fibromyalgia can be very difficult to unwind. So I talk to them about the benefit of that and whether they want to do that. What are the practicalities? We can do testing on blood, saliva, and cheek swabs. That's what a buccal swab is. We usually can get results really quickly for cancer testing, and for gene panel standard these days is 4 to 6 weeks. Far cry from 3 to 6 months. That used to be the case, but sometimes we need 3 months when we're doing a very expanded test. And we've talked about some is MBS funded, some is state government funded, some is privately funded. And often once you find a diagnosis, the family, the testing on the people in the family is free. So I'm giving you some examples here, and I'll go through them in a clinical scope that I showed earlier. Classic things. You've got someone whose family history, someone who died suddenly. Think about an inherited cardiac condition, and often that can be funded in the family. Not always, but often can be funded, meaning no out-of-pocket charge for the test. Someone who's family planning and they've got a family history of intellectual disability and a nephew. Think about referring them to a general genetics clinic to talk about testing them to see if they're carrying that rare condition their nephew has. Middle-aged people may be interested in having genetic testing to see if they're carrying something. And there's about a 2 to 3% chance that if you just pick up an average middle-aged person off the street and screen their hundreds of genes, a select section of genes, not just every gene, but genes where there's something you can be doing. They're called actionable genes, cancer genes, where it's like a breast cancer gene, like a BRCA gene, for example. If you've got a BRCA mutation, okay, there's things you can do to prevent stuff. Same with the cardiomyopathies, there's things you can do. If you screen a panel of about 200 genes and the average person walking around with no history, about 2 to 3% of them will come back with a genetic mutation that guides their management long-term. And people may want to fund that, and that's called a proactive genetic test, about $500 again. They can do that right now, fund it for themselves. And you can order that testing, actually. Again, you can order it. As long as you do a consent form and the patient's happy to pay, there's no issue with the GP ordering the test. You might get patients who've had a letter stating that there's a condition in the family, and that's someone you might want to refer to a local genetics clinic to talk about. And the example is, there's a neurological condition in the family. We write family letters and that are de-identified that allow the family to access care. And cancer genetics is huge. I'll talk a bit about that. But if you have a patient in your sphere, in GP land, who's got a family history of breast cancer or ovarian cancer in particular, and they're really worried, and they're worried about their daughters. There's now cancer genetic testing available at $500 roughly for them. If they want that peace of mind, do I carry a BRCA gene mutation or not? Given I lost 2 aunts at 45, and it was awful. Their journey was horrendous. Or I lost my mother. And this is the sort of stuff I see all the time. And so I often see mother and daughter pair, for example, who both come in. The mother's having a test, but the daughter's listening in to hear what it means for the mother. And irrespective, mother's positive or negative, there are some recommendations for the daughter. So that's why I know I often see, sometimes I see 6 people in one consult, because I want their parent and all their 5 kids and their 3 siblings to all hear the same advice. And they are a close family. They want to be involved. They want to hear what it means for them. I encourage it so that they can all be informed of the same counselling, pre-test counselling. And then you all know about NIPT and referring to a pregnancy, your local pregnancy genetics clinic with an abnormal result. I think...
Question again?
Yeah, sure.
Another one. So there seems to be a very long wait time to get an appointment for a public genetics clinic.
Yes.
Is private a bit quicker? Is that your experience?
Yeah. Well, of course it is. It is. There's no doubt. You know, I at Monash where I work, our Monash Genetics Service is the only service statewide that does whole of life care. We see from before pregnancy to end of life stuff. We see prenatal, pre-pregnancy, prenatal, children, adults, old people, everything. And in our service, the standard referral is a year-long wait. Now, if you're pregnant, different story. You'll be slotted in within 2 weeks. That they automatically jump the queue, or if there is a clinical urgency, if the clinician says, you know, this might change how I look after this patient in the next week, we will arrange that. That will be done. But the average patient is a year. And, you know, in private, I know there's 2 other geneticists in town. My own wait list is about 3 to 4 weeks at the moment to get in for the first appointment. So it's much better than public. But keeping in mind, if you're referring to the private geneticist like myself, I can access Medicare funded testing if it's available, but I can't access state government funded testing. So if they go to the public clinic, they'll be able to access potentially state government testing if 3 geneticists agree the test is warranted. But if they're happy to pay $500 out of pocket for a test, that's roughly the price point for most of these tests, then privately is a great option for them.
So then, sorry, springboarding off that. So then if they see you decide they need to have a public hospital funded test, is it sort of somewhat faster for them you to refer into public, or do they have to go back to the queue?
You would think it would be, Shamal. It's a good question, but no, it's not. In our department particularly, I make it that's sort of jumping the queue, and whilst they've seen me, so let's come back to the question. Your question was, do I think they warrant a publicly funded test? So a classic example is in my first appointment, what I do is I draw a big family tree and I talk about the whole family history and the personal history. And I tell them, I don't arrange the testing then. So I tell them then and there what my impression is about what the test will cost. And I tell them if it's going to be Medicare funded, and because I'll know that by the time I've taken the family history and the personal history, I'll know if it's going to qualify for Medicare funding or not. I'll tell them, great, you're going to have a Medicare funded test. So you can come back next time. We're going to talk about the test in detail. Whoever else in the family wants to join, they can join. We'll arrange the test. If it's not, I tell them up front, if you want to come back, you don't have to come back to see me, but if you want to come back to see me, the test is anywhere between $500. And if they really want to, I've had some patients fund a $3,000 test. It's up to $3,000 for whole genome sequencing, for example. And at that point, they can decide, do you want to come and see me or not? And if I have a suspicion that they should have whole exome sequencing, but they won't qualify for the Medicare funded exome, for example, I'm seeing a child who's just not quite at that level where the lab will give them the Medicare funding, I don't refer them then into public. I can refer them, but our department will be very specific and not let them jump the queue, because there'll be other kids out there who are just as the same acuity who are doing their wait time on the public wait list, so they won't get in quicker. But I will tell the family that, from the outset that I'm unlikely to get this Medicare funded, so the out-of-pocket will be this much, whether it be 500, 1,000. If for children genetic testing, there's one particular test, we call it a trio test. We test the child and both parents at the same time, and that maximizes the chance of finding a genetic diagnosis. You find something in the child, you automatically check the parents, see if one's carrying it or not, and that's about $1,500. But if they don't want to do the trios from just the child, it's $500. So I tell them, you're not going to qualify for the Medicare funded test. Your options are to go to the public clinic and there's a wait list, or to fund it privately, $500 or $1,500 for that trio test, or not do testing at all. It's your choice. And that way they can make their choice. I know we're going to break soon. I just want to touch on this because this is what's going to take up the rest of the talk. One of the GPs submitted a question beforehand and said, the question was something along the lines of, how do we access genetic counselling for our patients in a timely manner? Firstly, genetic counselling is a lot of what I do is genetic counselling as a geneticist. We just tack on the medical expertise, and that's what makes a geneticist. Someone who's trained as a physician and who understands physicianly medicine on top of what genetic counsellors do, which is really important, which is they do have a lot of understanding about medical basics of genetic stuff that I talked about at the very beginning, but also what it means for insurance, what it means for your family, and in particular, psychosocial implications. Genetic counsellors are trained to navigate uncertainty, and I think I've got on the next slide, I'll take you here, the psychosocial aspects, maintaining what's called autonomy, helping the patient make the best decision specific to their circumstances. That's what genetic counselling is. It sometimes takes multiple appointments. And so I can offer that as a geneticist, not to the same degree as an expert genetic counsellor, but so can you. It's not anything, not rocket science. It's about tailoring the test to the individual and not testing people if it's not going to help them. Sometimes it's just going to create more anxiety and make their life worse. What's the point? I had a 32-year-old, for example, who was referred from Canberra. And I saw him on telehealth, who was adamant that he wanted dementia genetic testing. Adamant, because he had some cognitive issues. He's got some brain fog. He feels that his memory isn't quite right, but he holds down a job. And he feels that his higher order thinking isn't quite right. And over the course of 3 appointments, I convinced him to not test. Because my job was, and this is what we do in counseling, is why are you testing? And do you really want to know that you're going to get Alzheimer's somewhere between age of 50 and 60, that it's not preventable, that it's incurable, that it's progressive, that if you know about it now, you won't qualify any insurance, you may not qualify for certain jobs, God knows. I don't know what the implication is of a genetic diagnosis in your long-term career. Do you really want to know this right now? At the end of the day, he opted to test for other things like Marfan and brittle bones and stuff. But the point is, that's what we do in counseling, and everyone can do it. And going forward, we aim to mainstream genetic testing. In fact, a lot of stuff is, by mainstream, we mean that primary care physicians and non-genetic specialists be ordering genetic testing. That's why Medicare funding is coming online, to encourage people to order it themselves. And eventually this will become standard practice. But right now, in the rest of the talk, I'll talk about the complexity of counseling to give you an idea of the things that we talk about. And you can do these things too. There's no reason to stop you from doing them. But you may want to refer the patient for expert genetic counseling where you feel like you're out of your depth.
Okay, so one from Rolf is, all of the genetic tests seem available, they can seem endless. What are the penetrance of these tests, which is more likely to make meaningful value?
Yeah, so what you're asking is, which of the tests are the ones that have the most value? And value, I suppose, Rolf, is defined by how will it change the patient's care. But I will add to that, sometimes value is just in knowing for patients. So, for example, you have a patient with a peripheral neuropathy, okay, unexplained. That's a very common scenario. They haven't had alcohol, got no chemotherapeutics that could have caused nerve damage, no trauma to their nerves, thyroid's okay, all those kinds of things. Unexplained peripheral neuropathy. It's called Charcot-Marie-Tooth, which is the old name for this now group of like 30 or 40 different kinds of neuropathy. You can do a genetic test and identify the cause. It will almost certainly not change the patient's management. They will still have a progressive neuropathy that will get worse. But in our experience as geneticists, the power of that diagnosis cannot be underestimated. Some people, it's like life-changing. They're like, I've been through this diagnostic. I have no idea. No one knows. And you've just told me it's genetic. And the power can be, and that psychological power can be really important. So that's just the diagnostic, odyssey ending. So that's just my caveat to your question, which is that whilst the tests may not change anything, they can provide a lot of power. But then there are certain tests that will change management, can change how you look after the patient. The specific things, and I'll talk about them again, but in the cardiac sphere, lots of testing changes how you look, changes the drugs, the therapies, the defibrillator, the devices, the surgery. In the pediatric sphere, in critically sick children, it can really change management. Metabolic conditions, all of a sudden you supplement with an enzyme or supplement with a vitamin and things change dramatically. reproductive carrier screening, find the couple carry something, they can do IVF, prevent their child having a rare neurodegenerative disorder. It can be, life-altering for that family. So there's specific examples where genetic testing has a lot of value, but I just say that having a diagnosis itself can have a lot of value too. What was the other question, Shamila?
There's actually a few now. So one is junk DNA. Is it really junk, or are there treasures that we haven't discovered yet?
Yeah, absolutely. It's treasures we haven't discovered. It's 98%. It's those chapters in those books that we can read, but we don't know what those. It's like gobbledygook, page after page after page. But that's just gobbledygook now. It's like an undeciphered language. Don't know yet. It's by junk DNA. I was sort of partially being facetious, but partially being historical. That's what we used to call it. We didn't know what it did, so we called it junk DNA. It's definitely not junk. It's just not understood fully yet.
There's another question on genetic counselling. So do you think a GP would be in a position to manage the consultation in counselling? What sort of training would a GP need to do?
Yeah, so I'm now, is that the last question so far?
There's one more. We can pause and come back if you want.
Why don't you give me the other one, then I'll come back to the genetic counselling one.
The other one is diet and lifestyle activities have been shown to turn off certain genes. How does that work?
So what was the first part?
Diet and lifestyle activities can turn off probably expression of certain genes, and
yes.
How does that work?
Yeah, well, that's definitely your diet and your lifestyle modulate the expression of your genes. We know that for a fact. How does it work? I don't know. I don't know how it works. I don't know exactly how having a healthier diet and exercising more turns on and turns off metabolic genes. That's critically one of the things that's happening is you're having less metabolic derangement, and that's driven through, a lot of it's driven through genetic expression, meaning you've got your 20,000 books. They haven't changed. It's just whether you're reading those books more frequently or not. For want of a better analogy, just keeping the library analogy, it's the librarian, whether she reads the book 20 times a day or 5 times a day. That's what genetic expression is. And what dictates whether she reads it 20 times or 5 times, don't know. But certainly for cardiac, for neurological, for retinal conditions, ophthalmologic conditions, we counsel them and say the reason why your trajectory may be really good or really bad with the same genetic mutation as another person is probably to do with the environment and other genes that we don't quite understand just yet. And so there is modulatory factors, but I can't tell you exactly why. So back to that question about counselling, can a GP do it? What training do you require? So what I'm going to give you now is the Cook's tour of what a geneticist or a genetic counsellor tries to encapsulate in genetic counselling when we counsel a patient. Okay. Before I get into insurance, genetic counsellors it's a master's course, 2 years plus 5 years of working plus certification whilst they're working. So it's a long road to become a genetic counsellor. So of course, even geneticists don't have the same acumen and skills that they have. But I think you can acquire basic and really important stuff that gets you to a level that's really competent to later do a lot of counselling yourselves. I don't think you should go and do courses. I don't think you need to. I think that a lot of this stuff comes intuitively when you understand the concepts that are behind it. And much of it, genetic counselling, is based upon navigating uncertainty, helping patients understand that results aren't always black and white, and posing them scenarios. What are you going to do when you find out you have Marfan syndrome? That kind of question. Is it going to be a good thing for you or a bad thing? Because if it's going to be a bad thing, you don't want to know. Don't do the test. It's not going to help you. Don't do the test. On the other hand, it might be a really positive thing for this, as an example. So I will try and now give you an overview of all the things that we cover as geneticists and counsellors. The first is insurance. In Australia, legally, you can't be discriminated against when it comes to public hospital, private hospital, specialist care, GP care. It's all legislated by law. There's non-genetic discrimination. But where you can potentially be discriminated against is for those red insurance products at the bottom, because there is no legal protection currently. There actually is. You'll read about it if you go delving. There is a moratorium. By that I mean the insurers have craftily come together and said, as a group, without any law that pushes them or binds them, that we won't ask people about their genetic status if they're asking for insurance at less than $500,000 of cover. That's their self-designed moratorium. But that's a temporary thing. They can pull it away tomorrow. Doesn't apply above $500,000, and it's only there till 2024. It's there. My opinion is that it's a stalling tactic to prevent the advocacy that we do to the federal government to put it into law, like the United Kingdom has, to prevent discrimination in all fields of insurance. But we don't have that here, so we counsel patients and say, sort out your insurance before you do any genetic testing, and that includes, by the way, reproductive carrier screening, NIPT. Because not NIPT, forget about NIPT, but reproductive carrier screening. I'll talk about why that, because sometimes you pick up stuff that is important for the parent, even though you were doing carrier screening to look at what they could be carrying. Okay, so this is one thing I wanted to highlight, is beware that could leave them behind if they didn't know that they should have sorted their insurance out just in case before they did the test. This is just generally all the complexities we try and convey to patients. And I'm going to go through them now. Is in as much detail as I think you should understand, that you appreciate the complexity of what we do. The first is we talk to patients about the fact that a diagnosis in you can have implications for your health about the organ in question, the heart, the kidney, the brain, whatever it is, plus other organs. I don't know in some way what I'm going to find. If I do a 100 or 500 gene panel test, there is a possibility I'm going to find a condition that means you're also at risk of kidney disease and neuropathy. For example, Fabry disease is one. Fabry disease is a metabolic disorder, an enzyme problem. There's actually a treatment now for Fabry disease. There's a alpha galactosase. You can have Fabrazyme infusions, another reason to test for Fabry disease. And that manifests sometimes as just hypertrophic kind of a thickening of the left ventricle, but nothing else. But if I make a diagnosis of Fabry's, all of a sudden saying to the patient, you're also now at risk of kidney and neuropathy. So to prepare the patient for that possibility is, what if we find something that has more wide-reaching implications? Sometimes the gene panel is like 4 genes. Like, for example, familial hypercholesterol needs 4 genes. I'm not going to find a neurodegenerative disorder or a skeletal problem or I'm only looking at 4 genes to do with cholesterol. But if it's a broad test, prepare the patient and prepare them for their family implications. On the bottom, on the left there, that person with the arrow is the person being tested, but his sister may carry an X-linked condition because she's got 2 copies of the X chromosome, and she's got a boy who may develop the X-linked condition because he's got 1 copy. So an X-linked condition being diagnosed in the male can be really relevant for his nephew and for future children that his sister is planning. Okay, so that's just going to show the familial implications. The sharing of information point I wanted to raise is that in Victoria, we don't contact family members. That is, if person A, the square on the bottom left there, is referred to me, I don't contact his sister or his brother or his mother or his father or his nephew, etc. They have to come to me. I issue him a letter about his medical care, and then in my private practice as well, not just in the public, I issue them what's called a de-identified letter, and they can decide whether they want to share the de-identified one or the identifiable one with their family, or they can decide not to share. And if they decide not to share, that's their choice. I'm not allowed to chase. We as a group statewide have agreed we're not going to go chase. Whereas in other states, in South Australia, for example, they do mail outs, but we don't do that. So they have to come to us. We don't go to them. And the onus is on the person to share genetic information with their family if they wish to. The next is which genes to analyze. Just to give you a picture, this is a moving feast. Coming back to the library analogy, there are 20,000 books. Do you analyze these 100 or these 100? Every week, new genes are being added to what's called the green list, the genes that should be tested for a particular condition. And genes are being removed from that list. There, people are coming back and saying, actually, we used to test this gene, for example, OBSCM, which is in the middle on the right-hand side, or VCL right at the bottom, but it's no point testing it. It's not associated with the problem anymore. In fact, it confuses the picture. Why bother looking at this gene when it's not associated with the problem? So as geneticists, we vex over this issue. Now, when you do an MBS-funded test, the Medicare item number specifies and says, the lab must do at least these 30 genes. And in that scenario, it becomes very easy. You know that the Medicare Advisory Committee has assessed those 30 genes on the basis of experts, and you're getting a good test if you just do those 30. But when you come to a geneticist, often rather, I will customize that and go, yeah, we'll do those 30, but I know about another 15 that have just come up that are important, another 15 books that aren't on that 30. And if you don't ask the lab, they won't include the 15. but the 15 means you have a better chance of finding a diagnosis in you. And I might remove some genes off the list. These aren't so relevant because I know these genes really well. So which genes to analyze is an important question too. And then within the genes, I talked about all of us being riddled with mutations or variants. The reality is that we are full of variants, and most variants detected by the laboratory are all benign or likely benign. But the laboratory comes up with a classification for each and every spelling mistake they find. So if they do a genetic test that's called a whole exome sequencing, each of your 20,000 genes, and look for spelling mistakes, mutations, they will find literally hundreds of thousands of variants, of which 99% of them will automatically be benign or likely benign based on their computer algorithm. They're left with a 1%, which is still like 1,000 variants. And then they have to manually filter each and every one of them. That's why they spend some hours. They do the hours to do that. They can rule out many of them often, but they often have to whittle them down, and they give each and every variant a 1 to 5 classification, 1 being benign, 5 being pathogenic. At the extremes, it's really easy. If they're benign, they're benign. If they're pathogenic, it's like the lab saying, this is really clear cut. This is the diagnosis in this patient. There is no question about it. But that's not often the case. Sometimes we come back with what's a yellow gene, a variant result, an uncertain change. And that means the lab does not know. Is it the cause? Is it not the cause? Don't know. And that's what I mean by communicating uncertainties. We just know really well our ability to pick up variants or mutations far outstrips our understanding of variants. So we're much better at picking up that it's a spelling mistake, but what it actually means, we're not as good at. Shamail, any questions?
They're just on your previous slide with the list of green and red genes. So there's one question is that if we order a private cancer panel, e.g. prostate cancer, will the genetics company automatically customize for the useful ones and the non-useful? Or?
Yeah, it depends on the lab you do. So for example, if you go through Peter McCallum, which I order my testing through, Peter McCallum take pride in curating their gene list. It's literally what they do. Every month or every 2 months, they go over their list of gene analyzed and go, should they be on there? If they should be, great. If they shouldn't, take them off. Don't analyze them. They're useless. Should new genes be added? And this is a time-consuming thing. This requires someone to do some manual labor and review genes, gene by gene, to see, should this gene be added or not? And some labs don't do that. They just take, we'll just do what most people do. And every few years, they might add a gene if they're really compelled to, but they won't do it regularly. So that's where selecting a laboratory, this is, in here, top left, which genetics laboratory is really important. And that's why, as a geneticist, I take care to pick the right lab for the right test. I won't send someone for heart disease to Peter McCallum, for example. That's a bad place to send them for heart disease. I might send them to New South Wales Pathology, who has an interest in that. I won't, but I will send cancer testing there because I know they take pride in keeping a very accurate gene list.
And one more question about the moratorium. What happens afterwards as genetic testing is increased? Is the moratorium going to extend, or is this?
Don't know. It's an industry-driven moratorium. The insurance companies have come together and put a moratorium. What they do with that, I have no idea. So, I communicate to the patients. So I don't even rely upon it. Even if you want to get cover less than $500,000, I wouldn't rely upon it. They could call it tomorrow. They could have called it tonight, for all I know. And I'll find out tomorrow morning there's no moratorium any longer. So sort out your TPD, life insurance, income protection, have your policy fixed, because once your policy is active, they can't discriminate against you.
And the last one is variants of unknown significance. So they're more often benign, or is it no answer?
Yeah, don't know. Sometimes as a geneticist, I can guide the patient. Sometimes I'm very suspicious and I'll treat them as a pathogenic and I'll tell the patient it's uncertain. But given your history, I'm really suspicious. You've got 4 young kids and I'd rather screen them all for heart conditions rather than not screen them and then regret because someone has an aortic dissection and dies, and I had to screen them with echoes over 5 years old to pick that up. So I apply some judgment because I know how to read variants and I know what the lab is talking about. And I've done a bit of that myself as a geneticist, curating, sitting in a lab, actually doing their lab work. But sometimes I don't know. And I tell them, I simply don't know.
It's all of them for now.
Great, thank you. So I talked about genetic counselling. One important thing to flag is that we don't test children unless there's a really clear benefit. So if there's a BRCA gene mutation found in the mother and the daughter's 15, I always tell them, ask your daughter to come back when she's an adult. There's no point testing her now because BRCA-driven breast cancer doesn't occur in adolescence. It occurs at the earliest in their late 20s. So what's the point of her knowing for 13 years that she's going to have a high risk of breast cancer and, the anxiety, et cetera, that comes with it? Test them when they're adults, unless there's something that would change their management in the short term. And that it aims to explore harms and benefits. That's the whole point of the counselling. Is it better for you to have it than not to have it? Also, post-test counselling. We spend a lot of time, no matter how much you prepare a patient, a genetic diagnosis can be devastating. So I often spend time with patients talking them through the result after the test has come back, even no matter how much I prepare them. Some take it really well, some take it badly. You can't prepare everyone for everything. And so the counselling post and reframing the result and maintaining hope and all those things are really important. It takes time. So this is an example genetic test report to show you what it looks like with a VUS and a likely pathogenic. Coming back to this classification system, a VUS is that yellow variant, class 3, it's abbreviated as VUS. And so this genetic test report on the left here, and I can't use my cursor, but in the middle of the page, you'll see there's two genes. There's a table, and there's two genes there, DSP and Nexin. The first variant is classed as a class 4, that's likely pathogenic. And the second is a class 3B. 3B is the lab saying it's truly VUS. Coming back to the GP's, the question is, could it be benign, could it be pathogenic? Because the lab 3A, 3B, 3C. This particular lab does this thing where they subclassify the VUS into A, B, and C. The point is that this test is telling you that I found a likely answer for the patient. The DSP variant is likely pathogenic. So I think the lab is saying, I think this is likely the answer for this patient. But I also found another change. I'm not sure what to do with it. Does that mean the change is contributing, not contributing? I don't know. It leaves it to the clinician's discretion to try and work it out and to communicate to the patient. And sometimes we actually test multiple family members, children, siblings, parents, to try and work it out. And in some cases, over years, we can work it out. We can either move it up, meaning make it pathogenic and say, no, it is a dangerous change. This person's actually carrying 2 dangerous changes, not just one, or we can move it down. And that takes time, to test and do that. So I'm just going to open this blind just for some light. Right, so that should give you an idea of the variances that are reported on a genetic test report. And another example of a really complex test result. This is a test that shouldn't have been done. So this is a young boy who was seen by a colleague of mine. And because this test was free, this particular panel you'll see on the right, the test performed, it's called Invitae Skeletal Disorders Panel. This laboratory Invitae is wonderful. I use them all the time. But they have what's called sponsored testing. That is pharmaceutical company sponsored testing. So completely free testing, not Medicare funded, not state government funded, industry funded. And this was a 358, at the bottom on there circled, 358 gene panel for a boy who could have had a bony problem. But the problem is the broader you go with the test, even though it's funded, free, so to speak, the more likely you are to find uncertain results. And this boy had no less than 10 uncertain results, all of which then need to be teased out. Each and every one I spent going through and saying, is this relevant to his phenotype, his problem or not? It's really important. He's only 16. He's got 60 years ahead of him, 70 years ahead of him. I've got to give him important advice about what he needs to be screened. He needs to have his heart screened, eye screened, kidney screened, ear screened. What screen what? What about reproductive implications? What about his sister who's 16? What about his parents who could have adult onset disease? So this took hours to go through this. The point being that the broader the test you order, the more chance you have of finding stuff you don't want to find. So narrow your test as much as possible. Sometimes you have no choice. You have to go broad. But beware the uncertain, the broader the test. It might seem really easy. Oh yeah, just order a big panel, do the epilepsy panel, 400 genes. What if you find stuff that talks about neurodegeneration and blindness in adulthood? You really want to know about all that stuff. And what if it's not even relevant because it's all uncertain? So I wanted to highlight what, the complexity of what we do. And this is post-test counseling. And you've got to try and prepare the patient pre-test for this possibility when you do a really broad test. And so a genetic test consent form necessarily is a really long document. This is an example, Sonic Genetics form. I have my own form. Mine is 4 pages long, for example, because I need to make sure the patients understand it. And I sometimes tell them to go home and read it. And they often do take it home and read it and think about it and then sign it. And they often go away and they sort out their insurance, because the moment I tell them about insurance, their ears prick up and say, I was so keen to have it today, but I'm not happy with my life insurance. So I say, go away, sort it out, and then call me back. And then we can email you the electronic form and you do it. But the form has to be comprehensive to talk about uncertain results, incidental findings, familiar implications. And again, GPs can do this. There's nothing stopping you from doing it. You can order an in vitae skeletal disorders panel tomorrow. As long as you get a patient to sign a consent form, that's fine. But you may not be comfortable, and that's completely fine too, because this takes us about at least 20 minutes for me to do a consent. And that's someone who does it all the time. At least 20 minutes to go through consent. If they have questions, it takes half an hour just to do the genetic test consent. Forget about talking about what the condition might be, what the diagnosis could be. Now, I wanted to give you some examples of the kinds of things we deal with, back to this scope of clinical genetics. In each field, the stars represent areas with no filling that are MBS funded. So you can see in cancer, in particular, there are MBS funded. BRCA testing can be MBS funded, but they've got to meet the criteria. They've got to be young, family history of breast cancer, particular type of breast cancer, ovarian cancer, male breast cancer in the family in particular. All those things will tick boxes and get them over the line for the funded, meaning no charge test. They don't meet the criteria, or they're not affected themselves, but it's a family member that's affected and they're concerned about $500 to pay for the test themselves for a panel, which includes the BRCA genes, for example. Kidney testing on the top is now funded by Medicare. Many things in kidneys funded by Medicare. Cardiac, I mentioned, many things funded. Pediatric, many things funded by Medicare. All those have to be ordered by a specialist physician. They can't be ordered by GPs. Just that's the way the Medicare item number is worded. And then state government funded is everywhere else. Is that, you can come through a public clinic, and if the 3 geneticists quorum thinks it's worthwhile doing it because it will change what you do for the patient, there is skin, endocrine, neurological conditions, eye conditions, all that can be funded. And in pregnancy, if you're pregnant and you've got a baby with an abnormality, fetal malformation, or a family history of something, that's all funded too, all state government funded now, and now Medicare funded if you're pre-pregnancy. So on the bottom left, the testing that you already order, I'm going to talk about that next or soon. I'll come back to NIPT and preconception screening, but just to give you the scope, this is all different corners that we can. And in cardiac, because I'm trained as a cardiologist as well, what I particularly focus on is people with the question of Marfan syndrome. One of the things I do a lot is the stretchy bendy, the tall. The question's been on the top of that person's head for their life. Have you got Marfan? I've seen so many people who've come to me and said, every time I walk into a doctor's clinic, they say, geez, probably have you got Marfan? That kind of question. And that has been lingering. And they're like, I'm sick of this question. Like, how do I answer this question? And so cardiologists refer to me, GPs refer to me now, and through an examination and an echo, and I can provide them a rough idea. Sometimes they meet the criteria off the bat. That's very rare because Marfan is rare. Not every tall person has Marfan. Marfan is a 1 in 1,000 condition. So out of 1,000 tall people, maybe 20 to 30 will have Marfan. But the genetic test is king. So if they want to self-fund the test, which is no Medicare funding for, they can pay $500 and have a test and have a question answered unequivocally. You either have Marfan or you don't have Marfan. And the other thing that Marfan is with aortic aneurysm. I want to highlight that, we actually change how we look after patients with aneurysms based on the genetic test results. If they've got Marfan, we operate earlier. If they've got the other conditions right at the bottom, those rarer conditions, vascular EDS, low SDs, would operate earlier because we know their risk of rupture of that aorta, of dissection is much higher. Just to show you that treatment implications I was talking about, make a genetic diagnosis actually changes the care of the patient now, not like later. It's how you look after the aortic aneurysm right now. And in Marfan, it's a big deal. If you make a diagnosis, you're committing that person then to say, you're at risk of aortic aneurysms along the whole aorta, not just here. You have an echo every year, a whole CT of the aorta, or an MRI if you're a female, every 3 to 5 years, because there is a chance. But the good news is if you pick it up, something can be done. We can intervene, save your life literally. Because what kills people with Marfan is the dissections, the aortic pathology, not the eye problems, not the being tall and gangly. What kills them is they die suddenly from their root rupturing. This is, I'm going to whiz through this quickly. In cardiology again, you've got a patient with unexplained cardiomyopathy. Think about a genetic cause, because now there's Medicare funding for it. So the cost barrier is removed. And if you find a genetic cause, we change our management rapidly. Institute new medical therapies, new antiarrhythmics, devices, big deal. Defibrillators and pacemakers go in earlier to try and protect them from long-term complications. So think about that in the cardiac sphere, people with a family history of sudden death, unexplained death, and they're thinking, what if it could be me next? Unexplained cardiomyopathy. So ejection fraction 50% or less, unexplained, don't know why. Think about it. Could it be a genetic condition? And often those people will qualify, because if I do a big family tree, like I'll show you if I have time, I'll eventually find someone who's died suddenly, and I can justify it to Medicare and say there's a family history of sudden death, even if it's the great grandmother. Medicare won't care, but that's my job to find that history to then go to Medicare and say there's enough here to offer this patient a funded genetic test. And that's what I do when I draw the family tree. Now, pregnancy-related testing, the last 15 minutes or so. You all know about carrier screening and NIPT. This is just to demonstrate that you can, carrier screening is before pregnancy, NIPT is during pregnancy. Some concepts, because I have had some GPs express me they don't quite understand the difference. And so I want to quickly just summarize the concepts. Carrier screening is looking at up to, at the moment, 400 different genes to see if parents, one or both parents, are carrying a condition silently that could affect the child. NIPT is back to the bookshelf analogy. NIPT is looking at whether whole bookshelves are missing or duplicated, whole chromosomes. And so what's circled there is chromosome 21, bookshelf 21. So trisomy 21 is when you have 3 copies of that bookshelf, and you can pick that up on NIPT, right? And that's in pregnancy. So they're looking at fundamentally different things. Carrier screening is looking at single gene disorders, single spelling mistake in a single gene shared by both parents. NIPT is masses of genes, hundreds, thousands of genes duplicated in a bookshelf or missing in a bookshelf that signifies significant pathology in that baby. If you have any questions on that, please ask now. And I'm happy. Shamila, were there any questions at this point?
There are 2 specific questions, not on this topic, so we might answer them after.
Yeah, sure. Now, what I wanted to highlight with you guys was the fact that carrier screening can be arranged through all different kinds of laboratories because it's patient funded. On the left is I've given you the Monash summary. Shamila has, on Health Pathways is a bit of a summary and a guide for patients. She'll show you that. Shamila, do you need to go to Health Pathways shortly?
I will. I'll go to it in a bit.
Yeah, I'm almost done.
Yeah.
And same for NIPT. But the important thing with NIPT I wanted to highlight was that some NIPT are better than others. So some NIPT just look at whole bookshelves missing or duplicated. Other NIPT look at the other horizontal oval here. Individual shelves of bookshelves, sub-chromosomal problems, certain genetic disorders are not just whole chromosomes missing or duplicated, but you can pick up a shelf of a bookshelf duplicated, for want of a better analogy, and that's choosing a better NIPT. So, for example, Percepted BCGS is a very good test in that I have nothing to do with Percepted in terms of financial arrangement, but I know they do a very good test because they screen for disorders that, for example, the Sonic test won't pick up. If you want the best available NIPT test for a patient to maximize the chance of finding a genetic disorder in the baby. Pitfalls of carrier screening. I already talked about this, that you could identify a condition in a parent, a prospective parent, that could be relevant for their own health. This is a real result of a 25-year-old woman who had a carrier screen with her partner, and it found on the left a condition that's listed as autosomal recessive. So you think, okay, it has to be 2 people, the baby has to have both mutations. But on the top right, when you read the description, this individual is at risk to have a calpanopathy herself. Carrying one spelling mistake is enough to cause a muscular problem in her. And she wasn't warned of that beforehand. So it was a big shock to her. She thought she was being tested to inform her pregnancy, not about her own health. And so just be careful that a carrier screen can actually potentially pick up conditions. And NIPT can too. You pick up trisomy 21, the mother could be carrying a translocation that then informs the risk of future pregnancies. So NIPT is not just about that baby, it's potentially about the parents too. In short, you refer the patients to us. We do a whole lot of appointments. We do genetic counselling. We do testing. We even get family in. I get family in all the time. Next week, I'm seeing a mother and her 4 sons all with, and the mother's got hypertrophic cardiomyopathy. She's worried about her 4 boys. So they're all coming to hear the same advice, phenotyping them all, meaning doing echocardiograms on them all, and then giving the whole family a considered opinion. And then we refer them back. As geneticists, public or private, we don't look after them long-term. We have no capacity. Except for me as a cardiologist, I look after some cardiac conditions, cholesterol, cardiomyopathies, arrhythmias, etc., because I can do that as a cardiologist. But other stuff, I refer them back to whoever sent them to me and say, this is the genetic test result. Here's your follow-up plan. And on the horizon, ultra rapid testing. I talked about 12 hours. This is not just pie in the sky. It's now, this on the left is what we do right now for children who are sick in ICU. We do 3-day turnaround whole genome sequencing, and it means it saves them weeks in pediatric intensive care or neonatal intensive care, makes a diagnosis quickly, can institute treatment. We do it right now, state government funded for inpatients. On the right is a case report of a boy who presented in the morning with a cardiomyopathy, and the night was diagnosed with a rare genetic condition, and 2 weeks later went on to have a heart transplant, all because of that genetic test that says this isn't going to get better. This is a malignant, awful cardiomyopathy. It's only going to get worse. Don't look for recovery. Look to transplant this boy, and he was transplanted. So in summary, think about genetics when you've got someone who's got unusually severe common disease, diabetes, but really young onset diabetes. Dementia, but really young onset dementia. Cardiomyopathy, but so severe and so young, or just young. Why they got so young? They got a family history, and if they're family planning, they're the kinds of areas you think about it. I've talked about funding testing for lots of conditions now, Medicare, state government funded, and out-of-pocket costs are much more affordable than they used to be. Shamila will show you the contact details for your local health services. What you should know, you may not know, is that there is a genetic counsellor that's available, business hours, at all these health services, at Monash, at Royal Women's, at VCGS at the Children's, at Royal Melbourne, at Genetics in the Northeast, at Austin, to take a call. Most times, if they can't take it, then they'll call you back to answer your questions. So call them if you want, and ask them, the public clinics. There's a counsellor there who can help you, guide you. Should you refer, should you not, what should you do next? It's the website for my practice. You got a patient with you, and if I can take a call, I'm very happy to help you, give you some quick advice on, should you refer or not? What should you tell the patient then and there? What could the cost be? What could the implications be? Just some rough guide. I'm very happy to take calls. I take calls all the time from GPs who just want a quick advice, what to do next.
I'm just wondering, Angela, how are we doing for time? Because there's some pretty good questions that I want to.
Yeah, we've got 8 minutes left. There's some questions if we have to. I think Dr. Verma, if you're happy for me to pass them on to you, we could probably do a follow-up. Shamala, if you're happy to start your presentation, we'll see how we go.
Skip the PowerPoint because they're just very simple cases, and I might just go straight to the pathways. So also, I can't tell how fast your screen sharing thing is, so let me know.
Working well.
If it's too fast or anything, let me know. So it's mainly for those who are not familiar with HealthPathways, and just showing you how to use a genetic suite. So we've been working on it with Dr. Verma for the last couple of weeks, and so it's not quite yet ready to publish, but probably in the next week or so. So what I'm showing you is a draft, so it won't look pink when you guys see it online. So to find the genetics pages, that's our HealthPathways homepage. Whoops, scrolling down to medical. Under medical, we have our genetic suite. So because this is draft, it won't be exactly the same view as what you see, but these dark ones are the ones that we've been able to update recently. So they'll come up live in the next week or so, hopefully. So again, it'll look slightly different when you guys see it. So we have a pathway on assessing genetic risk. So this is for any patient who you think, like Kunal was saying, that they seem a little bit young, they seem a little bit, it's too many family members, with this sort of issue. Do I need to think about a genetic test? So in this pathway, it'll guide you through what kind of testing we can do, what sort of information we should be looking through, how to do a family history, and what we can do, if we find an issue or who we send them to. There's a pathway update on familial cancer syndromes. This is it's a broad pathway. So again, it's looking for how are you going to work out, is this breast cancer familial, or is this just, a lot of bad luck in the family? Is it multiple people over 60, or is it quite a few people who are younger? What type of cancer? So it's guiding you through the style of questioning and how we can assess, where we can find some, relevant referral guidelines for GPs, what kind of testing and funding might be available, which Kunal just covered, and where we can send people as well. In addition, there's 2 specific pathways on breast and ovarian cancer syndrome, so specifically looking at things like BRCA. Again, just ignore the highlighting, that will be gone soon. But drawing your attention to things like, what are the risk categories? How do we know who's at risk? What do we need to do with them if we identify that they're in category 1 or category 2? What's covered by Medicare? And we'll link out to MBS wherever it's relevant for us as GPs to do so. And there's a questionnaire in here, which I think I've just scrolled past, but the I Prevent questionnaire, which is somewhere here. And when I slow down, I'll find it. But anyway, so there was a question before on Lynch syndrome and how do we know what's Medicare covered? The answer to your question will be in this pathway, so on colorectal and endometrial cancer. So it's again, what type of cancers, which family member. There's a whole subsection on Lynch specific cancers. So a whole section on Lynch syndrome. And other sort of familial cancers that you can find as well. So again, it's going through how do we work out who's at risk, what do we do with them once we work it out, what are the criteria we should be looking for, and once we've found that information, how serious is this, and who do I send them to? If they meet the criteria, to where we send them to. If they don't meet the criteria, but we're still a bit worried, what kind of screening should we be doing? So that info is in there. Under pregnancy genetics, the one that's been reviewed just now is on prenatal screening and diagnosis of fetal anomalies. So again, I won't go through it in too much detail, but pretty much hopefully everything you need to know on the difference between your NIPT, carrier screening, second trimester morphology scans, nuchal lucency, all this information is in here as well. These 2 are probably the ones that are more, info heavy. Genetic laboratory testing, we've done quite a big review on this one and added a lot of information in here. Specifically, it was the first Health Pathways region that I'm aware of that has a section on pharmacogenomic testing, which was no small feat to get on here. So it's going through when would we in general practice do a pharmacogenomic test. So there's a couple of examples where it might be something that's relevant. So, different medications, treatment-resistant depression, and a lot of resources down here to help, upskill, at least in a short way. Limitations to testing as well. The RACGP is going to be publishing a genomics update by the end of the year, and the RCPA will also have a new guideline available early next year as well. So some of this information might change then. So this pathway is trying to put in all the genetic testing that we can kind of access easily in general practice, not the weird, rare, wonderful things, but the stuff that we might commonly see. So a section on carrier screening, NIPT, and where to access these services. Other sorts of tests that we can do. So we can technically we can do chromosomal microarrays, we could do Fragile X testing, we could do cystic fibrosis. So some information under these tabs on each of the tests, what the Medicare conditions are, and then who we should order them for. And a small section on the bottom for direct-to-consumer testing, which again is more so if people are coming to us with, I want paternity testing, I have an MTHFR mutation, what can I do with this? So we've got some more, a bit of information and some resourcing on how to counsel patients through that. And the last one I want to highlight is our genetic health advice and referrals. So this is a question on where do I send them and where do I go? So this is a point that was made before, is that each public hospital, which I certainly didn't know, has got an on-call geneticist available or genetic counsellor available for us. So we can just call a local hospital and ask for them. A section on pregnancy-related genetic services and, who meets the criteria and which hospitals. So if you're not familiar with Health Pathways, there's a lot of drop-downs, which is a bit frustrating, but it will show you, Eastern Health, Mercy, Monash, and contact details for the individual services as well as their referral guidelines. So we've got one section on pregnancy-related genetic services, one section on familial cancer services, and the last one on general genetics as well. So yeah, hopefully that wasn't too much, but yeah, like I said, within a week or so that'll be live and you should hopefully get a link sent out to you as well. But yeah, that was my talk. If I can work out how to stop sharing.
Thanks, Shamala. That was a fabulous session. As well, Dr. Verma and Dr. Panwa, thank you for your time for tonight. It's been an absolutely fabulous session. We do have a couple of questions that are outstanding, but I'm mindful of the time, so I'm sure that we can follow those up for you and include those in the follow-up email that we send out to everybody, which will have a copy of this presentation as well as an attendance certificate. We'd be really grateful if you could please take a few moments to complete the evaluation survey at the end of this session. And please remember that your PHN is here to help you. So just as we went through the Health Pathways there, we'll send out a link to Health Pathways or information about Health Pathways if you're not already using it, and how you can actually get support to sign up to use it. And as Shamala said, is that once the pathway is live, we'll let you all know as well. So I'd like to thank both our speakers tonight. It's been a fabulous session. Thank you everyone for joining us this evening. Enjoy the rest of your evening and have a great night. Good night, everybody.
Thanks, everyone.